So hi everyone. My name is Delaney Fischer, and I am soon to be a rising fifth year in the neuroscience grad group, and I'm a predoctoral trainee on the Addiction T32. I'm super thankful to be able to present to you all today. And as mentioned, I typically investigate like preclinical mouse models, but today I'll be presenting a clinical paper about repetitive transcranial magnetic stimulation as an add-on treatment in cocaine use disorder. And I was really drawn to this paper, particularly because there's a little bit of a translational component for me with my background. And just from some previous experiences I've had in lab, stimulation in general, whether it be deep brain stimulation, repetitive transcranial magnetic stimulation, has kind of been a hot topic in both human treatment, but as well as in preclinical animal models. And so something I've been familiar with is optogenetic modulation or optogenetic stimulation in rats. And it really just drew me to this paper, that there's kind of this very clear translational component that we're looking at. And so just to get into it, so this paper focuses on repetitive transcranial magnetic stimulation, or RTMS as it'll be referred to within the text here. And it's a non-invasive method of treatment that can be performed on conscious patients, and it typically takes about 40 minutes a session. And what it is, as you can see here on this image on the left, is that an electromagnet coil is placed on the surface of the brain, and a magnetic field is given off to the patients. And typically, it's used for a variety of neuropsychiatric disorders, such as depression, which is where it mainly got its FDA approval from, but also mania, schizophrenia, anxiety, OCD, substance abuse as well. However, it's a little unclear exactly how RTMS works, and that the paper here kind of gives a little bit of ideas about the depth, about functional connectivity within the brain, particularly within the dorsolateral PFC. And so we're going to dive into kind of how RTMS has been implicated within a possible treatment modality for addiction, but also do we have some sort of kind of correlational suggestion about how it works. And so, as I just mentioned, one of the main areas that stimulation has been used on is the dorsolateral PFC. And so, in general, cocaine users show hypofunctioning frontal striatal connectivity. It's also been seen with major depressive disorder, which I mentioned is where the original FDA approval for this treatment came from. And so, within the dorsolateral PFC, there's this idea about how it's in charge of top-down executive control. So the PFC has a major role in decision-making, working memory, risk avoidance, craving, as well as personality and other traits like that. But it's also been suggested that there kind of is the big hub that has functional connectivity with other regions. And so on the image on the right here, we're actually seeing when TMS is applied to the left dorsolateral PFC, we see bulge signal changes in other areas of the brain. And so it's thought that there's this functional connectivity where you potentially activate one region and then it therefore either activates or inhibits another based on its connectivity patterns. And so again, with the PFC, we're mainly talking about a glutamate likely connectivity change, but how does that affect specific regions? And so we can see here that, for example, it increases signal change in the caudate and the anterior cingulate, but not in the auditory cortex. So it's not that every area has this functional connectivity, but particularly within the DLPFC, it's been suggested that perhaps there is functional connectivity with the ventral medial PFC. And that's another region involved with emotional processing, reward value, and arousal control. And what's really interesting about these two areas is they kind of counteract each other from our current evidence within craving and impulsivity. So, for example, when we see increased activity in the dorsolateral PFC, we see an attenuation of cocaine seeking and attenuation of craving in previous literature. However, that when there's increased activity in the ventral medial PFC, it actually enhances cocaine seeking or enhances craving scores, and vice versa. So it's hypothesized that there is potentially a functional connectivity between these two regions, which this paper also explores. And just something that I wanted to point out, as Dr. Childress said, like this is a really hot topic of transcranial magnetic stimulation, but it isn't new. It's just kind of understudied. And so in looking through the literature, there are a variety of studies that suggest that RTMS can have very beneficial effects on those with cocaine use disorder. However, what this paper does point out is they're the first study to have a double-blind randomized control trial. So in going through the previous literature so far, what we know is that, or what we have seen in literature is that like one session on the dorsolateral prefrontal cortex in 6 males reduced craving after 4 hours. But we don't know if that applies in females. We don't know the longevity of this effect, et cetera, et cetera. And the majority of studies are like this, where it's either really short-term effects with no follow-up, or the subjects are low in number, or there's non-specific targeting, for example, both sides of the PFC versus right or left, and it's kind of unknown the actual longevity of these effects. What it is believed is that it is beneficial, but again, the functional connectivity and how long the effects last are kind of unclear. So, as I mentioned, one of the really, at least for me, really impressive things about this study was that it's a double-blind randomized control trial. And I actually had to kind of look up what exactly that meant. And so what I found from some other papers was that it's considered to be like a golden standard within clinical trials. The goal of double-blind randomization is to eliminate bias, have proper controls, for example, making sure you have a sham group and an actual active stimulation group, and providing strong evidence of causation, which again, I think is really important when we're trying to establish if there is a potential of functional connectivity, that it's actually caused by either RTMS or not. And so just on the left here, this was in the supplement of the paper, but I thought it was just really interesting to just follow for those who might also not be familiar. And then were pretty stringent in their criteria, and so they ended up excluding 117, with 107 of those not meeting their criteria. So these included things such as you actually had to be in another method of treatment for cocaine use disorder, including either pharmacological and or therapy at the time of the study. They included females, but if you were pregnant, you were excluded. Any interaction with other drugs and you considered being addicted under DSM-5 rules, you were excluded, et cetera, et cetera. And so they ended up with 54 subjects, and then they did a randomization again, so either allocate to active or to sham, and they received a double-blind intervention of either, again, the actual treatment or not. And then following that, they did what was considered, I believe they termed it a compassionate inclusivity. So if you were originally in the sham group, you were able to participate in active stimulation to see if it would help you after the 2-week acute period. And they had 2 different follow-up points after the acute period of 3 months and 6 months. And on the right-hand side here is kind of an overview of that. And so again, the double-blind acute phase lasted for 2 weeks. And then it was an open label maintenance phase where any participant was able to actually get the active stimulation. And throughout that time, there were MRIs conducted as well as different subjective analyses relating to craving scores, impulsivity scores, anxiety, and sleep. And furthermore, they actually also conducted urine tests on the subjects to see if it actually affected them taking cocaine. And so, again, in the beginning of the talk today, I told you that there's been high suggestion that the dorsolateral PFC has functional connectivity with the ventral medial prefrontal cortex. And so one of the things the authors in this paper did was they started with a normal control group, kind of establishing that, yes, there is functional connectivity in a non-cocaine using group. And so what you can see here in A is that there's a green dot in the middle of these red and blue dots, and this is kind of their target area that they're hoping to hit with the RTMS. And you can see here where they actually ended up applying it. And then we can see on B and C kind of the bold production of how the map came into play. And in D, we're looking at actual connectivity of other, or activity of other regions based off of either activation or inhibition with activation of the dorsolateral PFC. And so on the right here is kind of the output of their findings. And so again, you can see there's positive correlation with the dorsolateral prefrontal cortex as expected. And we have a negative correlation with the right ventromedial prefrontal cortex. So again, here they're kind of providing evidence that there is a functional connectivity between these two regions, in that when at least the dorsolateral PFC is activated, the ventromedial prefrontal cortex is inhibited. However, we can't definitively state the opposite in this, but again, their target is going to be the dorsolateral PFC for their subjects in this study. And so after their acute 2-week period of the RTMS on the left dorsolateral PFC, they started by giving their subjects different types of subjective scoring, including 2 measures of craving, a measure of impulsivity, as well as anxiety, depression, and sleep ratings. And intriguingly, they had no significance in one of their craving analyses, but they did in the other. And so something that I was actually wondering if the group would clarify on as well is that there's multiple assessments of craving. I mean, it's all subjective, and it was making me think of translational models and how when we are looking for either like a phenotype of depressive-like behavior or anxiety-like behavior, how we run multiple behavioral assays. And so I thought it was actually very, what's the right word I'm looking for? Very thought out and very thorough for them to do multiple craving assessments, because if they had just done the CCQ now assessment, they would have missed an actual finding. And so I was really, again, just impressed with their design and making sure they covered all their bases. Interestingly, they had predicted that the RTMS would actually help alleviate anxiety, depression, and sleep deficits. And what they found was actually both the sham and active groups had improvement in scores relating to anxiety, sleep, and depression. And they don't elaborate on this too heavily in the paper. They just say it's a non-specific effect. But I was curious about the actual subjectiveness as well, is that what they say is that anyone who's enrolled in this study actively is seeking treatment and actively indicates that they are looking for a way to sort of alleviate having cocaine use disorder. And I think maybe the potential of even just being in this study could be an effect on these topics here, because again, we had a non-specific effect with sham as well. So that was just some interesting food for thought that I was having. Oops, sorry about that. In terms of going back to this connectivity then, so again, we saw a decrease in craving and a decrease in impulsivity scores with the RTMS in the left dorsolateral PFC. And what we also see is that it increases the dorsolateral PFC, ventral medial PFC functionality connectivity compared to sham groups. And so again, what we're looking at here is sort of in the green and red, the sort of connectivity score, and it's it's a lower score here, saying that the main cortical target of the dorsolateral PFC causes a decreased functionality in the ventromedial PFC. And kind of the goal that they claim here is that they're trying to excite the executive control network, which in hindsight is actually dampering other regions such as the ventromedial PFC, which is more of a drive control network. But very interestingly, we do see that there's actually an increased connection with the ventral medial PFC and the right angular gyrus. And this is impacting the default mode network, which is kind of thought to be like the more background network. And I just thought it was really interesting to see that a region that actually wasn't the target is having more downstream effects. And so, again, I think it's signaling that when we do stimulation, that there really is a lot of layers that maybe we don't understand, a lot of indirect effects, but that are very interesting. And especially when we consider that, again, the right angular gyrus has been implied with other sorts of addiction and craving relating to like gaming and internet addiction, but not particularly indicated within cocaine in the same capacity as like the dorsolateral PFC. But maybe there is more to this connectivity map than has originally been explored and is worth further exploration. So as I mentioned, they did their 2-week acute phase, and then they did a follow-up for 3 and 6 months. And again, at the baseline to 2 weeks, they had their sham and their active group, versus at the 3 and 6 month point, they allowed for everyone to do active. And interestingly, what we see is that the maintenance phase still has a reduction in craving, which is really exciting. Even from the baseline VAS scoring, which we didn't see at the 2-week point, but with extended prolonged treatment, we are seeing that. And the CCQ now is, again, significant at that time point. Impulsivity is maintained for up to 3 months, but then is back to baseline levels by 6 months. And again, the anxiety and anxiety scores are not significant at 6 months. However, the depression scores still are. It appears that some maintenance is being retained at this point, which is really exciting. And again, they were doing the sessions daily from the acute phase, and then once they got to the maintenance phase, it was only through. And considering that the subjects were also in other treatments that could have interacted differently, I actually thought it would be interesting to see if there was a way to kind of trace each subject or group each subject by their other types of treatment modalities that they were exploring. Because they indicate in the paper as well that one of the hard things with any sort of clinical trials with different time points includes just maintaining your subjects. And they do acknowledge that by the 6-month point, they had lost a lot of subjects in this study, and that may be diluting some of the effects. And so I think it would be really interesting, again, to just see either those who remained the whole time, a connectivity line, something of that, because we're making assumptions off very different numbers when we don't look at it that way. And not that it's totally an assumption, because there is definitely statistically like maintenance occurring here, but the ends are definitely different from baseline to 6 months. And so I'm just curious if the majority are decreasing in that on that time point. And lastly, as I mentioned, they also discussed how they were using urine samples to actually not subjectively understand if the subjects in the study were continuing to use cocaine and how the stimulation was actually affecting them with their taking habits. And what they found is that there is an association with a significant reduction in frequency and amount of cocaine used. And again, that is by subject self-report. And within the urine tests, a lot of subjects were still testing positive. And they basically justified that it's a little bit hard to do this kind of analysis because at the month before the study, a lot of people were not in full treatment, not again, receiving multiple modalities of treatment at that time. And with over the course of the study, a lot of different factors came into play. So while they do acknowledge that it's associated with a significant reduction in frequency in cocaine used, they do acknowledge that the beginning of the study with their pre-month may have driven it, because you can see that it's actually maintained at a very low level throughout, which is great, and may be indicated of RTMS, but also just might be indicative of the high pre-month study frequency in grams. And lastly, in looking at the longevity, they also saw that the left dorsolateral PFC, right ventral medial PFC connectivity did not remain significant over the time course. However, the right angular connectivity with the ventral medial PFC did, but only at the 6-month, not the 3-month time point. And so, again, I was very curious if the data had been plotted a little bit differently, if we would have seen more enhanced connectivity either at the 3-month time point for that ventral medial PFC right A and G connectivity, or even if there was potentially a continuation for some subjects within the left dorsolateral PFC and right ventral medial PFC. I would have been really interested to see if the different pharmacological interventions played a role in this as well. So within the supplement, I don't know if any of you checked it out as well, they list every single subject and 1 or 2 or 3 medications that those subjects are on throughout the duration of the study. And I think there could have been some really cool interaction effects with understanding how treatments together can cause different either functionality connections or different scorings related to craving and impulsivity that we've been talking about. So overall in the paper, they show that acute RMTS decreases craving and impulsivity, and that this effect is maintained 3 months in maintenance with having a lower session levels of RTMS. They show that all subjects had improvements in anxiety and depression scores, so non-specific effects of improvement. And while there were no changes in cocaine use assessed by urine test, whether the answer is yes or no, self-reporting showed less frequent use and lower amounts of cocaine used. And lastly, and what I think is really interesting, is the functional connectivity was increased between the dorsolateral PFC and the ventral medial PFC, although it wasn't maintained. And the ventral medial PFC and right angular gyres was maintained, with the latter correlating with age, sex, and years of cocaine consumption, but not with craving. And really what they are pointing out here is that the stimulation seems to have caused some sort of functional connectivity, but it's not directly related to the craving scores that we were seeing. There was no statistical correlation there. However, there was a correlation with either age or with males and females, and kind of parsing through functional connectivity maps and kind of getting a better understanding about like what causes cravings, but also how are the connectivity patterns of certain regions changed with use during treatment, I think is something that I would love to know more about. But in conclusion, they state that RTMS may benefit those with cocaine use disorder as an additional modality of treatment. And again, one of the things that they made really clear here is that they don't expect stimulation to be a cure-all, and there's a lot of different types of stimulation that need to be considered, particularly with how often it's given, the frequency it's given. So again, here they did acute with a 5 hertz repetitive for thousands of stimulations per day, and their stimulation sessions only lasted 13 minutes, while some other papers said theirs lasted 40, and they did 4 times the amount of stimulations. And kind of trying to hone in on what is the proper method of administration of RTMS is one big question, but also trying to understand how it affects the brain with these functional connectivities are another big question. And it's really exciting that this research is getting a lot of traction. Papers are coming out. Even within my kind of background reading, there were a lot of preprints that I was really excited about seeing on bioRxiv. So hopefully some of these questions will be answered shortly. But yeah, thank you.
Good job, Delaney. I mean, one of the things that's fun about this paper is it really does, and you've touched on it in your presentation, highlight some of the challenges of this new territory, sort of still the wild, wild west, people trying to figure out, what are the parameters and how, you know, how do you compare apples to oranges from one paper to another with people doing, a few thousand versus many thousands, or using exactly the same hertz. It's still an evolving area, and I think it's heroic that they actually did, a double-blind, randomized study, because that's going to be the thing that will help things move forward rather than the anecdotal things that had been previously uh, reported. And even some of the ones that were sort of more controlled, this is still yet a step forward in trying to do that. I would comment that the other thing that you noted is that obviously multiple measures give you multiple sometimes question marks. So craving is something that's tricky anyway. It's something that is measured multiply in different kinds of trials that aren't even RTMS, and you sometimes see an impact on one measure versus another. So self-report measures are notoriously tricky. On the other hand, since it is a complaint that patients have, and it's a metric that's often used in trials, I'd also quickly toss in, and then we can certainly plenty of things to discuss here, is that urines do tend to be if we're talking about gold standards because people often underestimate their illicit use of cocaine, and that's been shown over and over again. And so it would be great if they had an effect that actually would also show up in the urines, but it may not be at this stage that they have something that's quite big enough in the way of an effect to show up there. I think it's also cool that they have these effects that tend to occur. Everybody who's in the trial had seen some of these benefits on anxiety, sleep, and depression, so that they call them nonspecific. It may just be an effect of being in a trial. It may not even be a nonspecific effect of RTMS. But at least when they have these measures and show that these things are changing or not, it gives you a comparator to the things that you're interested in if you're looking for cocaine-related measures. I also thought, I had one other quick thing. The other thing that I thought was really a plus, and you highlighted it too, is that they're really trying to get some nice objective measures in terms of these connectivity effects that they can then in turn link to whatever clinical benefits they might show. So the functional connectivity, the top down between DLPFC and ventromedial prefrontal cortex, even though it wasn't maintained, being able to show that period is pretty cool. And basically, I was interested too, but I don't have as much reference for the fact that the VMPFC is having these downstream effects on the angular gyrus. Haven't really thought much about the angular gyrus. I don't think about it when I'm lying awake at night, but it is something that people have looked at. And so it's an interesting thing that even though it wasn't their initial perhaps focus, that they've got something there that's maintained beyond the acute effects. And curious that there's some effects with age and sex, but not with craving necessarily, as though it may be a different dimension or a different construct. So I think you hit on the highlights. It also, this kind of article also does remind you of just the challenge of trying to do this work. When you saw the people that they actually had to eliminate, it was a whole bunch. And then they still end up with people who have a lot of heterogeneity. So when you looked in the supplement and you look for the fact that people are on medications, you're thinking, oh my gosh, how will we be able to detect an effect on RTMS or sham because there's so much else going on. So I would say it this way, to try to put a positive spin on it, is that this study was able to show benefits, and that's atop what had to be a pretty heterogeneous baseline, right? Because you've got these other potentially active treatments going on. Sometimes, for the sake of homogeneity, a treatment trial might say you aren't to be on anything else, at least for this next X number of weeks, so that we can try to understand the effect of the treatment we're giving you, and that even if you're on some other things, since there is no FDA-approved medication for cocaine, it's not like you're depriving them of an FDA-approved medication. You would look for people who are not currently taking a medication for cocaine use disorder, and then you get into the whole thing of taking other medications that they're just taking for their comorbid disorders. It is
Right.
it is really wild in terms of clinical studies to try to get homogeneous samples where you can actually do what you want to do, which is sort of a study that will allow you to make some causal inferences uh, with modest sample sizes, which is what you end up with after you've put in some exclusion criteria. I think it was 20 in one group and 24 in the other in this study. And you think, well, that is a modest sample size. It is, but I always try to flip it around the other way when we get critiqued for those smaller sample sizes, is saying, well, yeah, but if you're able to show something even in a study where you were modestly underpowered, then it's a stimulus for doing further work with larger samples. So that's some of the things that I would say if people were attacking this study.
Well, that's true, but as an add-on study, I mean, if you look at the size of add-on studies for depression, they're
Yeah.
bigger.
Oh
Um,
yeah, they are. I'm
yeah,
teasing. I mean,
yeah,
you're always going to feel more confident when you have more participants, but it becomes, a decade of gathering subjects in order to get something. If you're a single site with a smaller infrastructure, which is what we've been at. So it takes us forever to get a large sample of people with cocaine treatment outcomes. And so for me, I'm very sort of always the holy grail is to sort of get to the point of being able to link whatever your measures are, whether it's connectivity or an activation to a task to outcome, so that you can say that you've got something that you think is a substrate that people ought to be able to try to address with treatment to either enhance the top-down modulation of the DLPFC or to whatever your metric is. And
Well,
that's the
So,
hope.
so I was interested in the fact that connectivity increased with years of cocaine consumption because their population compared to our population at Temple, and I assume your population at Penn, they did they had about 10 or 11 years. We see more like 25 or
15,
30.
I was going to say 15 to 20 is more uh, our range, our
Uh-huh.
sort of, I think our average in our recent studies was 19 or 20. So, it's a large number compared to that. I'll have to say it's interesting that those 44 people had that much quote unquote reduction in cocaine use. The self-reported use was low. I think they may have been having more use than that. That would be extraordinary to have people, even if they have a lighter use history, to have such a low cocaine use during that follow-up period. Mary may want to comment on that, but I mean, it's relapse is the specter that hangs over all of these things.
Yeah.
But they're viewing this as an add-on, not as a standalone, and and that's fine. But if you had a choice, you would love to have an add-on added on to something where people are all kind of receiving the same thing, and then you're adding on to it. So, for example, a nice simple behavioral treatment or something, contingency management or something, and now you're going to add on, um, your brain stimulation to that. That might be your druthers rather than having a number of different medications. Because it could be really interesting interactions, but with these sample sizes, it'd be very, very hard to sort out. That's all.
Yeah, I think it's so interesting that they noted again in the supplement that like everyone who enrolled in this study indicated that they wanted to like have treatment, like they are actively seeking treatment. And with all of the other scores, I thought it would be interesting if they had put out like, do they think it's helping them? Because I wondered if that was a part of it. And again, I work with rodents most of the day, so I can't ask them how they're feeling or if they think it's working or what they think about it. And so when they had that non-specific effect of like lower scores of anxiety and depression and or better sleeping, I was kind of curious if it's common for like people enrolled in trials to like is it because they think it's working or is it maybe the other treatment? I don't
Well,
know.
it can be both, right? It can be that there's actually a healthy placebo effect, whether it's a trial that's for antidepressant or whether it's a trial for an anti-anxiety medication uh, or an anti-addiction medication. It's not uncommon for a substantial chunk of people to feel that it might be benefiting them. And, it doesn't mean that it might not be, but that's why you
Right.
have the comparator group. So I don't know what since I think that probably the urine rates for cocaine were probably higher, obviously, than self-report in both these groups, and were not different. It's harder to assess placebo. But what you could do is look at, the placebo, the group here that did not receive the active RTMS, and basically see what they look like pre-post, and basically see for the two groups if there's any difference. You'd like to see what you have begin, for your sham group or for your non-active group. What is the rate of reduction in craving that they have? Because you have to assume that that's not based on the active intervention, right?
Right.
So that gives you a kind of a placebo rate, and then you can look at what the change is in your other group relative to that. People used to worry a lot in medication trials for cocaine. Kyle and I always laughed at this, Mary would too, that, oh my God, you're going to have such a high placebo rate, you'll never be able to detect, a benefit of the medication. Well, certainly for urines, that's not the case, right? For urines, the harsh truth is that relapse is relatively fast, that within 3 months, we would have lost probably half the people. And basically, when we say lose, that means they stopped coming in. And the assumption is that they did not enter Penn graduate programs, but that they actually had a relapse to their drug use. And so basically, the drop away from treatment is really substantial. We equate that with relapse. And we have not been bothered by such a high placebo rate. People used to worry about this, but it's the opposite for us. For the most part, we have a lot of people who drop away quickly, and it's hard to retrieve them and get enough people to stick around long enough to demonstrate a treatment effect. By the way, I would comment that it's important to think about how you select the participants, because if you require that people are, say, for example, abstinent before they come in, like they have a cocaine problem, but they've been abstinent for the past month, now you're going to get a very different sample. Now you're going to get a group of people who, in terms of their endowment, their dorsolateral prefrontal cortex wiring, it's a group of people who have been able to establish abstinence on their own and/or motivated and/or, but it's a different group than just taking everybody who walks in and says, yes, I want to be in a treatment study. So everybody in our studies is quote unquote treatment seeking, but that doesn't mean that they're treatment seeking every hour of the day or every day of the week. Sometimes it's a waning motivation and they drop away. But if you do put in a criteria for people that are on their own able to begin to establish abstinence even before you do anything, that's going to be a less severe group. They're going to be able to stick with treatment better, and it's a subgroup, but it's a group that you may have more success with keeping in for a treatment trial. So very important. And when I use these blanket statements talking about all cocaine patients, well, they're heterogeneous. Certainly there are people who are less severe. So even though they have a history of 15 years, if you have someone who recently has been able to pull it together and is able to demonstrate some abstinence, there's something probably different going on with that person. They may be in a different place. They may have some different abilities, and they basically may have a better outcome. The strongest predictor of how people will do in the next 8 weeks is how they were doing in the last 30 days, right? So what you've been doing is a very strong predictor of what you're going to do, but that's not exactly a malleable treatment target. You can't change history. So we're always looking for what goes along with that in terms of a brain substrate to see if we can actually have something that we could address, whether it's with stimulation or whether it's with a medication. I think it's great, though, you tackled a clinical article with a lot of complexity and in an area that's hot, but it is, hot with an asterisk. It's still, there's a lot developing here. And in terms of just the simple parameters for this new technique, it will probably be the case that 5 years from now, it'll look, the landscape will settle out a little bit in terms of people having done the parametric work, which is very tedious to do, right? Think about it, all the different possible parameters, just as it would be with a dose response study for a medication. But you have here a frequency, how many pulses you give, and how many times a day you give it, and how many times a week you give it. It's a few layers more complex than choosing a study dose.
Yeah, definitely. I mean, even sometimes I know I get frustrated trying to figure out like my control groups, and then I read this and I was like, so I'm never complaining again.
It's really, I mean, it's just, and that doesn't mean that this is not a useful technique, not at all. In fact, um, for treatment-resistant depression, for people who haven't responded to or not fully responding to the antidepressants, it's been FDA approved for
Yeah.
benefit. And so, and I've seen it for people who've actually not been able to benefit and sort of lost hope and then were able to benefit. So yeah, it's a thing, but it's still a really challenging thing in terms of actually knowing the parameters, especially in the domain of addiction, where it's a little bit later coming in than compared to depression, to see how it will work out. But I think kudos to you for choosing something that was in this domain because it does highlight the challenges of doing controlled studies, right? If you think that essentially a dose response curve is the important thing, and it is for anything that you do, what constitutes a dose?
Yeah.
Adequate dose. I mean, it's sort of empirical, right? It means that you need to run, it's not a group of rats that you can order up and run this in 2 weeks. You actually have to somehow gird your loins and do a clinical study and look for efficacy, and then try another set of parameters and look for efficacy. And so one of the things that can be very helpful, and that's another reason that this kind of study is useful to highlight, is if you can find an intermediate, like endophenotype. In this case, for example, they're taking their DLPFC, VNPFC connectivity, and if you show that that's well associated with clinical outcome, then that's great because that gives you a proxy that you can use, and that means you can do the studies much faster, right? So if you can show, fill in the blank, that that's your endpoint, or in the kinds of studies that Mary and I are trying to do, that the brain response to cues in the limbic regions is very predictive of outcome. Now, if you're screening a medication, you can use that proxy measure without having to do a full outcome trial if you can show that those measures are well related to outcome. So one of the things that will be helpful for this path to do is to show which of these markers is actually strongly related to outcome. That'll help with trying to get faster at doing this.
Yeah, that makes
Because
total sense.
it's if you decide it's connectivity and you can show that this number of frames, this number of pulses, this had a bigger effect on connectivity than this one, and you can show, but first you need to show that the connectivity change hopefully is related to your clinical outcome of interest. And craving is yes, it's one piece, but definitely if possible, you want to see the actual drug behavior because there is a problem with self-report of drug use in our field because people are embarrassed. They want to be good patients. They want to, feel good about what they're telling their care providers and the people who are interested researchers. And this is not just the case for substance abuse. This is the case for people who are, taking their asthma medications, and they say, "Have you been using your?" "Oh yes, I have been." Your diabetes medications. How are you being compliant? Human beings are not as compliant as would be great for their blood pressure medications, their diabetes, their asthma, and it's true for their addiction medications as well. So one thing about this kind of study is if they're providing the pulses right there on site, at least they know that people got the treatment.
Yes.
Because the other thing that we deal with is that if you're not doing an inpatient study or a screening study where you're actually administering the medication and looking at the brain parameter, just a regular old clinical trial, it's wild. We have people who are coming in and while they're in the waiting room, you can see them pushing their pills out because they don't want to be viewed as non-compliant or acknowledge they're non-compliant. But they need to return their pill pack and they want it to be empty. So it's a challenge. It's a challenge. But this study highlights the challenges, shows you sort of where the field is, where it's starting up, and you've highlighted several of the places that the research will have to go before this actually, is ready for prime time. But it's it's important that they are actually trying to do randomized controlled studies.
Yeah, I especially looking at some of the very preliminary early studies, I was like very impressed with like their design setup, again, just like their questionnaire. And the supplement was very thorough about exactly what they were hoping to do with all their different like analyses and everything. And I just thought like, again, it was very well designed, even with like the limitations that we were just talking about. So
All the inherent limitations.
yeah.
Yeah, and as I want to do, I've talked too much, but there are other people on this Zoom who might like to chime in, things that they've read about or heard about RTMS. Mary, is there anybody working with RTMS at your shop? Dr. Morrison? Oh, I think you're muted. You're muted, Mary. Sorry. We see you smiling, but we cannot hear you. No.
Sorry. I don't know how to use blue jeans.
You're good. You're good. We can hear you now. I was just asking
Yeah.
how many folks that are working with TMS in your shop, either for substance use disorder or other psychiatric
Yeah,
disorders.
unfortunately, we don't have a TMS machine, but a colleague of mine in psychology and I have been talking to different TMS providers about getting one. And actually, one of them, I think it's Brainsway, has an indication for smoking cessation
Yeah,
with
yeah.
the FDA.
Oh, that's interesting. I didn't know they had gotten that far with beyond treatment-resistant depression. That's interesting. Yeah,
Yeah.
that's good.
So we talked, there's four. We talked to Brainsway and Mag Venture, and then we've talked to some local providers, but no, we don't have anybody working with it.
There's a little bit of a colorful history since we have a moment. Johnny O'Riordan was, as a resident at Penn many years ago, interested in trying to forward this, and basically as a technique for, at that point, treatment-resistant depression. And he had a lot of energy, and he did some of the preliminary studies that actually went toward the pivotal trials for getting FDA approval. And his device, the one that they used, and its grandchildren are the ones that are at the Penn TMS facility, and Johnny eventually went to full-time practice in Cherry Hill, but he basically left a legacy that's really fun there because they do have a TMS group, and at our place, in addition to the use for depression, I think there's interest in trying to do some things toward addiction. But Yvette Shalene at Penn is the person who's using it in treatment-resistant depression,
Uh-huh.
and she is combining it with brain measures, obviously trying to look at what you're changing in the way of connectivity, the kinds of outputs that you were talking here, but not for substance use disorders there yet. But there have been several people that have been interested, and so I'm interested to see if it'll be something that people will pick on here as a new tool, which, by the way, is not mutually exclusive with the other tools we use, right? Because you could see how you could do a regimen of this. You could then see if that impacts a task with fMRI, so that if you're using that as a proxy, you could see how this affects that. So there's ways of combining these things together.
Yeah, so Johnny is very interested in teaching. He teaches our residents about TMS.
Yeah.
They come over. And actually, we have a resident who's going to Stanford to do a neuromodulation fellowship
Fun, really
after
fun.
working with Johnny. So
Yes,
So
he's quite the advocate. His whole career has been really sort of, he's been an impassioned sort of pioneer.
yes, so for preclinical researchers, it's always possible, to get some experience and call someone up and say, can I spend a half day with you?
Absolutely. Absolutely. Any other questions or comments for this final Journal Club of the academic year? Delaney, we're grateful to you
Yeah,
for
that was great.
picking up the torch here and doing this and I know some people have already begun to have their summer vacations and conferences. There's a CPDD conference literally going on this week that I didn't see any way to schedule around it, so I wanted to make sure we got this opportunity in. Anybody have any other comments, thoughts for Delaney?
Oh, good job.
Thank
Good
you.
job, Delaney.
Yeah, thank you so much for allowing me to present today. This
And
was
it's really,
I really enjoyed preparing for this.
and your comments were all thoughtful and right on target. And the good slides too, by the way. I know how long it takes to make good slides. Those were very good.
Thank you.
Thank you, everybody. And see you in the fall for the next Journal Club. Okay, bye-bye.